Good afternoon. My name is Bridget Walsh, and I am a Senior Policy Analyst at the Schuyler Center for Analysis and Advocacy in Albany. Welcome to the Moving on Maternal Depression webinar series presented by the Schuyler Center and the Postpartum Resource Center of New York. This project is part of a national learning collaborative to advance policies that improve prevention, screening, and treatment with an emphasis on racial equity and culturally relevant practices in policy and systems change. One of the projects for the Moving on Maternal Depression is the webinar series that we're presenting today. And I'm going to turn it over now to Sonia Murdoch, the Executive Director and Co-Founder of the Postpartum Resource Center of New York, who will share a brief overview of our organization and introduce our speaker today.
Thank you very much, Bridget. The Postpartum Resource Center of New York is pleased to collaborate with the Schuyler Center in bringing everyone this webinar series on maternal mental health. I'd like to begin by briefly sharing an overview of the programs and services of the Postpartum Resource Center of New York. And we're grateful in New York State that through a collaboration with the Office of Mental Health and the Department of Health, that Governor Cuomo, his maternal mental health initiative. So starting off here with the slide. With the Postpartum Resource Center of New York, we've been helping New York State moms, dads, and families get to the help they need since 1998. And we have a statewide toll-free helpline, which now, due to the pandemic, we are available 7 days a week with the helpline as well as online contact form. And we provide free and confidential emotional support, educational information, healthcare, and support group resources, many of them virtual right now. We also provide patient education, patient-centered care. It's very important that these moms, dads, and families are educated with the #1 medical complication related to having a baby, perinatal mood and anxiety disorders. We also have our awareness campaign called Ask the Question. Very popular area on our website is with patient education, sharing our stories of hope and healing. We have a statewide advocacy team as well as volunteer network. And these moms and families are sharing their stories further to break the silence of maternal mental health. With community resources, here's information with the Postpartum Resource Center of New York and Postpartum Support International. Our overall vision is called Project 62, where we are building 62 perinatal mental health parent support networks in all 62 counties. We want to make sure that all moms are getting to the help they need. And it's a great pleasure today to introduce to you a pioneering maternal mental health program here in New York State. So thank you very much to Dr. Deligianides for being with us here today to present to all of us. Dr. Deligianides received her medical degree from and completed her psychiatry residency and chief residency in psychopharmacology research at the University of Massachusetts Medical School. Prior to and during medical school, she trained in neuroscience research at the National Institutes of Health. After residency, she completed additional research training in behavioral endocrinology and experimental therapeutics at the NIH and a visiting fellowship in neuroimaging at the Martinez Center for Biomedical Imaging, Massachusetts Institute for Technology. Dr. Deligianides joined faculty at Zucker Hillside Hospital, Feinstein Institute for Medical Research, Zucker School of Medicine at Hofstra Northwell in September of 2016, and is board certified by the American Board of Psychiatry and Neurology. Dr. Deligianides is the Director of Women's Behavioral Health at Zucker Hillside Hospital. Dr. Delagenides actively participates in national scientific committees and gives scientific presentations nationally and internationally. She is an associate member of the American College of Neuropsychopharmacology, a member of the Society of Biochemical Psychiatry, the American Society of Clinical Psychopharmacology, and the Marseille Society of North America, Perinatal Mental Health. It is a great honor to present to you Dr. Delagenides.
Good afternoon. I'm going to share my screen here. Thank you so much for the opportunity to present today. Just going to go to slideshow. Very good. All right, again, thank you so much for the opportunity to present and share our work here at Northwell Health in maternal psychiatric care. I'm Dr. Delagenides. Thank you for the lovely opening and welcome. Today, I'm going to cover a few items that we've been working on the last couple of years, initiatives really to improve maternal, especially perinatal psychiatric health, mainly at Zucker Hillside Hospital and Long Island Jewish Hospital, North Shore University Hospital, but also additional initiatives across our health system. I'm going to start talking about some of the new opportunities we've created in education and training. We believe education is one of the most important things we can do as specialists, as clinical specialists in perinatal psychiatric health, to train our upcoming clinicians and the community in perinatal mood and anxiety disorders. We've also taken a look at opportunities to increase prevention of perinatal mood and anxiety disorders. And I'll talk about one of the preventative programs in collaboration with obstetrics and gynecology that we've recently started. Also, we've certainly been a center for treatment and referral here at Zucker Hillside Hospital. The Perinatal Psychiatry Ambulatory Center started in the early 2000s, and then we later opened an inpatient perinatal psychiatry unit here on site in Glen Oaks, New York, in Queens. And I'll talk to you about opportunities for treatment here, how we've developed those programs, but also have sought collaborations across our health system to provide integrated care within OBGYN practices. And then I'll just very briefly discuss, as Director of Research, some of the research that we're doing in just a couple of slides in developing new treatments and training our learners here at the medical school and in our healthcare system on developing new treatments for postpartum depression. So as you know, perinatal depression is common, underdiagnosed, and undertreated. That's why we're also committed to trying to fill these gaps. Approximately 12% or 10 to 12% of women giving birth suffer from perinatal depression. That's depression either with an onset in pregnancy or after delivery. There are numerous professional organizations, national and international, that recommend screening for depression in pregnant and postpartum women. Including the professional organizations for obstetrics and gynecology, pediatrics, family medicine, psychiatry, and numerous others. Unfortunately, however, only a third of women with perinatal depression are identified in clinical settings. So it means that 2/3 of women are not even being detected. Of the women who are detected in clinical settings, only half of those receive treatment, and that's half of the 30%. Of the women who are receiving treatment, either with psychotherapy, supportive treatments, or medication, only half of those, according to this recent publication, are receiving adequate treatment. So that means an adequate dose of a medication or adequate contact with a therapist. And of those receiving treatment, adequate treatment, only half of those are achieving remission, which means that only approximately 3% of perinatal women who are receiving treatment are actually cured of their illness. These data suggest that our ability to detect and treat depression in perinatal women is much worse than in the general population, and serves as a potent need for us to pay attention to this patient population. And as you know, maternal suicide is the leading cause of direct maternal mortality in the first postpartum year. Data from the United Kingdom and also from the US and other countries indicate that 1 in 7 deaths are due to suicide in women within that first postpartum year. And that's not even reviewing the multitude of impacts for mom, for the family, and for her baby if the illness is not treated. And so we focused much of our education and some of our intervention efforts on the need for screening. And so we often review some of the most common self-report tools that are meant as screens, and we educate clinicians across specialties within family medicine, primary care, obstetrics and gynecology, and pediatrics to utilize these tools and to learn how to use the tools to better detect perinatal mood and anxiety disorders. Many clinicians are familiar with the tools, and there are some other barriers of enacting the tools in their clinical practice. But some of those barriers are now being addressed with some reimbursement for screening in clinical practices. One that is very common in general medical practices is the patient health questionnaire, and that has been validated to detect symptoms of perinatal depression. Also, the Edinburgh postnatal depression scale. Depending on the practice, we really suggest that whatever is feasible for individual clinics to use or practices, to use whatever it is they feel comfortable with and have knowledge of, that they have the staff training on how to use these tools. It's important to recognize that these are screening tools and that women should not be reduced to a number, that you have to understand that the number, based on the number of symptoms that a woman's reporting, really could be a variety of different things. It could be an anxiety disorder, it could be a depressive disorder, it could be bipolar disorder. And the just going by the number does not mean that a woman is suffering from a psychiatric illness or that she immediately has quote unquote postpartum depression or perinatal depression. So we do so much education across our faculty, our clinicians, and our learners so that they really have the understanding of how to utilize the tools correctly, so that when they are able to then diagnose or treat or refer for treatment, that mom is getting the best care possible. We also emphasize that because these tools will pick up symptoms of depression, that it's also important that a subset of women may have a different type of disorder, a bipolar depression. And it's important that that is recognized if a woman has bipolar disorder, because the treatment options are different. And unfortunately, unlike perinatal depression and bipolar disorder, there isn't a comparable screening recommended for anxiety disorders, which are very common in perinatal women. But some clinicians do utilize a subscale or a couple of the questions from the full 10-question EPDS because they are so common. And it's important to know that there are tools for both screening, but also there are effective therapies. And this slide really just outlines some of the most evidence-based treatments that are available for perinatal depression. Psychotherapies are recommended for women with mild perinatal depression, especially for unipolar, so again, not for bipolar disorder. And those are a variety of things that focus on interpersonal conflict, cognitive behavioral therapy, mindfulness, peer support, and group therapies. And then there are subsets of women who may have sleep disorders or trauma history, and there are now specialized types of these treatments that can target those specific issues or histories in women to make it more personalized for women. In addition, for a subset of women who have more moderate severe perinatal depression, antidepressants are the first-line treatment, with some that are supported by randomized clinical trial data. So not all antidepressants have been tested in perinatal women. The majority of the antidepressants outside of Zulresso, which is the only FDA-approved medicine for perinatal depression, were first tested in major depression in men and women across all ages. But we do have some research data that shows support for some of the SSRIs or the types of antidepressants that are listed here. And more recently, you may have heard of in the news last year, brexanolone injection was approved as the first and only FDA-approved medication and works very differently than the other antidepressants. I'll talk to you a little bit about that at the very end because our research group is involved in some of those studies. In women who are treatment resistant, so there's some women who don't respond to some of the traditional first-line treatments or antidepressants for perinatal depression. And there are data supporting the use of different types of antidepressants, the older antidepressants such as the tricyclics, which can be used, and there's research data showing they can be very effective in women who may not respond to the first medicine that's tried. So then I'll focus now on really our, after just giving kind of a synopsis of the importance of identifying perinatal depression and that there are effective treatments available, I want to talk to you about some of the initiatives and the approach that we've taken here at Zucker Hillside Hospital and with our medical school, Zucker School of Medicine, and the nursing school, and across our health system for education. Because really here, there is a big gap that we wanted to address. So we have focused on what I will call PMADs, or perinatal mood and anxiety disorders. And really we have found across the board, there is a need for education around screening, diagnosis and differential diagnosis, how to differentiate from non-clinical depression versus a clinical depression, and then how to go about treatment. And if the clinician is not in a position to be able to treat, as it's outside others, especially how to refer. So we really started in several kind of buckets, and I'll bring you through those. We started at our medical school because we really believe that every physician should understand perinatal mood and anxiety disorders, no matter what area they eventually go in. So if they eventually go into OBGYN, pediatrics, internal medicine, family medicine, whatever they go into, they should have had some basic introduction to perinatal mood and anxiety disorders. So myself and some members of my team are very active faculty and teach the first and second year medical students. We have a series of courses at the medical school that go through clinical cases. We share videos of patients that describe their experience with perinatal mood and anxiety disorders, and we discuss how to utilize the tools, how to do differential diagnosis, and then how to approach treatments. Third and fourth year medical students now have opportunities to get more intense training in both outpatient and research perinatal psychiatry, and that's here at Zucker, and where they'll be able to observe patients receiving care at our treatment center. New to this year, we've started also reaching out to the nurse practitioners. And this has been both to the family practice NP students and the psychiatric mental health NP students. And again, different level of detail, but we still go through the screening, differential diagnosis, and treatment. This has been well received both in the family practice and psychiatric mental health nursing programs. We, for many years at Zucker Hillside, have had an intense interest in the education track in perinatal psychiatry. And the clinical program here was from at least the early 2000s that it began here. the residency program has many residency tracks. And so where there's adult psychiatry residents, so these are physicians who are then in the residency training, have decided that they want to focus and treat perinatal women and perinatal mood disorders, that they have specialized training tracks so they get all the expertise they need by graduation to then be practitioners of perinatal psychiatry. And then also what we've done is with our OBGYN colleagues and obstetrics, is to now embed didactics and training in perinatal mood and anxiety disorders. And again, we have different levels of the depth of how this runs, but we tailor it to the different subspecialties. And then really to get the word across. So I work in a large health system at Northwell, and so I've taken the opportunity to present at grand rounds and other trainings across our health system, both in departments of psychiatry and OBGYN, and soon we'll be branching out to pediatrics, to again do the same clinical training to reach as many clinicians and practitioners as possible. So now I'll turn to some of our efforts of filling in a gap regarding prevention. And so, yes, we can teach people how to screen and treat or refer, but if we can prevent perinatal depression in women at risk, then that would be ideal. And so I'll take you back to a recommendation last February. And this is the United States Preventative Service Task Force, and it's a group that makes recommendations for clinicians to enact across the country. And last February, they made a recommendation that clinicians should provide or refer pregnant and postpartum women who are at increased risk of perinatal depression to counseling interventions. They found that there's a lot of evidence that there are effective therapies to prevent perinatal depression from occurring in at-risk women. And they specifically said in the recommendation that women with a history of depression, current depressive symptoms, or risk factors such as coming from a low-income background, a young mother, or single parenthood, that they would benefit from interventions that have already been tested in clinical trials. And one of the interventions that they mentioned in their recommendation was the ROSE study, the ROSE intervention. It's an acronym for Reach Out, Stay Strong, Essentials for Mothers and Newborns. And this is an evidence-based medicine intervention. It was developed at Brown University by Dr. Zlotnick that reduces the risk of perinatal depression in low-income women by 50%. And it's already been tested in community prenatal settings with racially and ethnically diverse low-income pregnant women. And there are many now publications that have come out of the ROSE intervention series, and amongst them of the positive findings, also that ROSE is associated with increased breastfeeding duration as well. So preventing perinatal depression, empowering women, increasing resiliency, and also having additional beneficial outcomes. And so what we sought to do is to use the ROSE intervention, and I'll tell you a bit about that, because I think these preventative interventions are a real place, especially with the task force recommendation, where I'd love to see our clinics and our practices move forward, because these are interventions, preventative counseling interventions that are delivered in prenatal settings by prenatal clinicians. These are not necessarily behavioral health interventions. And so ROSE is a 5-session course. There are 4 separate 1 to 1.5 hour prenatal classes, and it's flexible. It could be split into shorter sessions. Then there's a 1 postnatal phone check-in. And overall, the program offers education to mothers about signs of baby blues or perinatal depression, stress management. There are some interpersonal or IPT therapy aspects of trying to teach and role play with women around interpersonal conflicts that are common around childbirth, but also skills for resolving interpersonal conflicts and setting goals. And then there's a postpartum booster. In New York State, ROSE is considered preventative counseling for high-risk mothers. And as defined by Medicaid prenatal care standards, the provider can be a physician, a nurse practitioner, or a physician assistant. And there are reimbursement codes for these interventions. So these are billable services for clinical practices to offer their perinatal women. And so we started this at our Long Island Jewish Hospital OBGYN practice, and we are looking at outcome measures, monitoring the Edinburgh Postnatal Depression Scale in those women and tracking them to see if we're preventing perinatal depression and reducing perinatal depressive symptoms in these women. And then the goal would be to then replicate that in other perinatal settings. Another example of a collaboration is with one within our health system, which is an integrated care model. And this provides kind of screening, diagnosis, treatment, and referral all within an OBGYN setting. And so the team that developed this program is the Northwell Health Solutions team. They have a behavioral health care management team that originally was really partnered with primary care practices, then branched out to pediatric settings, and then just this year expanded to work with obstetric practices to help them integrate behavioral health care. And so the program that they offer is an evidence-based model where they have an embedded behavioral health manager in the practice in collaboration with the physician or physician's assistant or nurse practitioners in the primary care setting or OBGYN setting. And then they have, Health Solutions has their consultant psychiatrists to work as a team to manage patients' depression and anxiety. And so the practices that are enrolled must screen all patients for depression and anxiety, whether that be with the PHQ-9 or the EBDS. It mandates that all women or all patients, if it's a general practice, are screened for depression and anxiety. And then for women who are found to be symptomatic, then the embedded healthcare manager will conduct an initial evaluation, will do follow-up assessments, and really does the triage of whether short-term treatment can be done within the perinatal setting or if there's an external referral that's required. And there's always consultation to the consulting psychiatrist to help with treatment recommendations, who is making the recommendations for, in this case, the obstetrician or the obstetric clinician to prescribe if medications are indicated. If a higher level of behavioral health care is needed, then the behavioral health care manager in the practice will help facilitate that referral. And so this really is focused on tracking the screening scores of the patients, tracking the metrics, the depression scales and anxiety scales, the scores over time to make sure that patients receiving treatment are improving. And it tracks all of their treatments so that an algorithm for treatment can be followed for the best care. The focus is on unipolar depression and anxiety, and the behavioral health care manager is able to give short-term psychotherapy directly in the practice, right in the same perinatal setting as they get their prenatal care. And then also case management, so education, outreach, and linkage to other services. The consulting psychiatrist is able to do telepsychiatry within our health system, so we're able to reach out across our health system. And really the consultations with the psychiatrist are for diagnosis clarification, medication management, and then really bridging when a higher level of care is needed for behavioral health. What we've done in the Perinatal Psychiatry Center here at Zucker Hillside is provide that perinatal expertise to the psychiatrist at Health Solutions. Perinatal psychiatry is a new area for them. And before they were in general medical settings for primary care and then pediatrics, where they had child psychiatrists to consult. We now are providing perinatal psychopharmacology consultation to Health Solutions to help them understand the very specific needs of perinatal women, especially both in pregnancy and if there's lactation. And then we provide, as the different practices are enrolled in their integrated care program, my team provides training to the practice on perinatal mood and anxiety disorder. So we go into the practice and we train them on screening, diagnosis, and treatment. So it complements the training they're getting on how integrated care will look for their practice. So, so we bring in that expertise so that more women can receive treatment without necessarily coming directly to our perinatal center here at Zucker. And so then I'll talk to you about what we offer here at Zucker Hillside Hospital. We offer short-term treatment here at the health center, mainly for adult women who are planning pregnancy. We offer preconception consultations, medication consultations. This is often when a woman is already receiving psychiatric care and they want advice on how to proceed in pregnancy or lactation. For those suffering with miscarriage or struggling with birth loss, we have therapists that are trained and specialize in those areas. We do treat up to about a year post-delivery, just so that we can continue to offer care to new mothers seeking treatment. We help facilitate their transfer to non-perinatal specialty care if treatment is still needed after their treatment, their short stay with us. And so we do have a warm line, and that number is listed here, the 516-470-4MOM. This is for non-urgent clinical referrals. Our catchment area is Nassau and Suffolk counties. Women do come to us also from the Bronx, Brooklyn, and Queens. Beyond that, sometimes it's hard for women to travel, especially with young children. But those are where most of the moms that we serve are from. And then if women are in crisis, they should be evaluated in the nearest ER because these are for non-urgent clinical referrals. At our center, we do offer initial telephone assessment and triage to see if our services are a good fit for the woman. We do standardized assessments, a comprehensive evaluation. We offer a variety of evidence-based psychotherapies and group therapies, medication management, and we hope in the future to expand what we're able to offer. We also have the largest dedicated inpatient psychiatric unit for perinatal women in the United States. It's a beautiful unit. It's such a blessing to have this unit. It's just a few years old. It's for women with perinatal mood and psychotic disorders who require acute inpatient care. The staff it's an all-female staff. They're trained in perinatal psychiatry. They've all undergone the Postpartum Support International trainings. It's led by 2 perinatal psychiatrists. We have obstetrics and gynecology consultation from our colleagues at Long Island Jewish. So they come right to the unit because we have a private gynecology exam room right on the unit. So the moms don't have to leave the unit in order to see the gynecologist or obstetrician. We have a breast pump area and many breast pumps. We have meditation, yoga, a lot of education, childbirth education, and they're adding to what they offer to women every few months. And it's just beautiful. This is not a mom-baby unit. I don't know of any mom-baby units in the United States because the infants are not allowed to stay. It's just, the way in the United States, I think that we're just not set up to deliver care, even though in Europe, these models do exist. So we do have a very interesting, when the unit was built, the chief nursing officer very thoughtfully created a private family room for family and infant visits, which is on the unit, but safe. It's in a safe area that allows privacy and safety from the main unit. So it was a really beautiful design with families in mind. And then we made, you know, there's so much of a need in the community to ask about our services and to how to find information. So we redesigned both our brochures. So now we have them as PDF. It sounds all new age, right? So we now have PDFs for downloading. I can print them and distribute them. They're both on the OBGYN facing and psychiatry facing websites. And so all the contact numbers and the services are listed there. And that was just updated just over the winter. And my last couple slides will just give an overview. I'm the director of research here at Zucker Hillside Hospital for Women's Behavioral Health. And we really take a broad approach to our research to fill in the gaps. We're trying to better understand perinatal mood and anxiety disorders, trying to understand different clinical phenotypes. So women present with different clusters of symptoms, and maybe they require different treatments depending on the different symptoms they are reporting. And right now, everyone really kind of gets treated similarly. So we're looking at clinical phenotypes, we're looking at genetics, genetic risk factors, we look at hormonal risk factors. And I'm particularly interested in understanding how the changes across pregnancy and after delivery affect brain functioning. The brain is a bunch of circuits that have to communicate well in order for moms to be resilient and happy and able to enjoy their family, their life, be productive, bond with their baby. But for a subset of women, they don't make this transition as other women do. And we believe that for some women, their brain circuit does not adapt to that change in hormonal milieu. And so we're looking at that to try to identify women who would be at risk. We do this with brain imaging, and also we've done a lot of work in trying to develop new treatments for perinatal depression, both medication and non-medication. And so we did some work, this is my last slide or two, on looking beyond what we normally can provide women. So before this medication, the Zulresso, was approved last year, antidepressants, really the majority of them worked on serotonin and norepinephrine and a couple other neurotransmitters. And the field was really stuck just looking at those agents as potential antidepressants or anxiolytics, medicines to combat anxiety. And my research had been in neuroactive steroids. And as I told you, I'm very interested in hormones. And these are breakdown products of progesterone, which is a major sex hormone. And they're really important for normal brain functioning. They really balance stress in the brain. And so we see women with so much stress in the perinatal period. And I want to try and understand if the steroids were really balancing stress as they should, or if in the women who develop perinatal depression, if if it wasn't, working as it should. And so briefly, we studied, and others have studied these steroids, and allopregnanolone was the steroid we had looked at, and others. It's made in the body, it's naturally made. It's made in the brain, the ovaries, the adrenal glands, and they modulate one of the main neurotransmitters in the brain, which is called GABA. They are different. These steroids are different from benzodiazepines that also interact with GABA receptors in the brain, but they're known to have a kind of calming effect based on their chemistry. And so a company had developed in an injectable, an infusion. So this is a peripheral IV infusion, 60-hour infusion of a synthetic man-made allopregnanolone. And it's a new antidepressant class, meaning it's unlike anything else that we can offer to men or women. As I said, it was a 60-hour peripheral IV infusion. So it's just like if someone was dehydrated and they needed normal saline infusion, it's the same sort of thing. It's a peripheral IV. But it was rapid acting, so it acts within hours. And it's a first-line treatment for moderate or severe postpartum depression. And so the key studies that are both published now that led to the FDA approval were studies that I've been working on for the last, probably 6 or 7 years. And we were involved in the randomized clinical trials of this synthetic allopregnanolone or brexanolone. And adult women were in the studies. They received the 60-hour infusion, either of the active brexanolone or placebo. These were adult women with perinatal depression. They were all postpartum, and they had to have moderate to severe unipolar perinatal depression. And then they came into, well, when I ran the study here, they were on 2 West, so they were here at our women's unit. They received the infusion, and then at 72 hours, they were discharged home. And then we followed up with them at day 7 and day 30. And this is all in the public domain from our publications, that the medication for 50% of the women at hour 60, so the y-axis is the percentage decrease in depressive symptoms, and the x-axis is the amount of time in days. And so remember, the infusion was only from hour 0 to 60. At the end of the infusion, women, about 50%, no longer were clinically depressed. And so their depression scores were no longer in the clinical depression range. For 75% of women who received the brexanolone infusion, they were at least 50% or more improved. And so they weren't cured of depression, or it wasn't remitted, but they were 50% better in 60 hours. There were side effects in the studies, and compared to placebo versus the dose in there, some of the major ones were dry mouth. But mainly, as you can expect from a medicine that works on GABA, the dizziness, presyncope, vertigo, sedation, and somnolence would be the main side effects that would be prevalent versus placebo. And because there was excessive sedation in 21%, the FDA put a black box warning on it, because this calls attention to the care that needs to be given in giving this medication. And in 5% of women versus 0 in placebo, the medicine caused sedation or somnolence that required the dose to be interrupted or reduced. In a small set of women, 4%, they also had a loss of consciousness or altered state of consciousness. This was typically just falling asleep. And so that occurred during the brexanolone studies, and typically was associated with IV pump malfunction than anything else. Everyone recovered within a short period of time with the dose interruption. Many mothers just had the pump restarted and then did well. As I said, this was FDA approved in March, but it can only be prescribed at certified facilities through a risk evaluation mitigation strategy program. This is a program that the FDA does for many medications, including psychiatric medications that have some risk associated with them, just to make sure that there are safety precautions taken. So in summary, we know that perinatal mood and anxiety disorders are common, they're undiagnosed, they're undertreated. We really emphasize our education and training on screening for both unipolar and bipolar perinatal depression. We recommend it in both pregnancy and in the postpartum periods. And we try to partner with our obstetric colleagues and with our other clinical colleagues to help facilitate screening in their clinical practices. Many are hesitant to screen because then they're not sure what to do. And so education is really key to that, and then providing them the education of how to refer or how to treat so that we can break down some of the barriers regarding detection. And then on the treatment is to educate providers that there are effective psychotherapies and medication therapies that are there, but they're underutilized. For brexanolone, I think this is really, a very important step forward in our treatment of postpartum depression. I think that although access to Zulresso is challenging because of its infusion. It's an infusion, so women are typically have to go to a hospital-like setting. That it just opens the door for us as physician researchers and others to develop similar types of treatments that would be even more broadly available to perinatal women. So it just opens up a whole new line of research and treatment for perinatal depression. And then again, really looking broadly at education, training new learners that'll be the clinicians of tomorrow, integrating programs of care. Not everyone can be seen by a super subspecialty perinatal psychiatry team. There's so few of us that are trained in this area that we can help train others to provide the care that's so desperately needed. And then to further what we're able to offer here at our treatment center, and then pursuing and completing and pioneering the research to fill in those current and future gaps in women's behavioral health care. And so with that, I'll thank you again so much for the opportunity to share a bit about how we've approached filling some of the gaps in women's behavioral health care at Northwell Health. Thank you again.
Thank you very much, Dr. Deligianitis, and also thank you, Sonia, for introducing this webinar. We hope that you've learned a lot. I know I found it very enlightening, and there's a lot to learn here. So we hope that you keep an eye on the Schuyler Center's website, which is scaany.org, and we'll have future webinars coming up. Thank you.